Welcome to AETCM, the emergency medicine channel. So, shall we start? A 65-year-old male, known case of type 2 diabetes hypertension with a previous history of chronic SDH and post bilateral barhole craniotomy done 1 year back, presented to the ER with a history of jerky movements of right upper limb lasting for about 15 to 30 seconds. In our initial 10-second assessment, patient was conscious and obeying commands. Coming to the primary survey, airway was patent, no pooling of secretions, no gurgling sounds, no hoarseness, no stridor, and no signs of any aspiration at present. Coming to breathing, air entry was bilateral and equal, no added sounds, respiratory rate was 17 per minute, SpO2 98% in room air. Coming to circulation, the BP was 140/80, pulse rate of 75 regular, and all peripheral pulses felt equally bilaterally. Two large bore IV cannulas were inserted at this point of time. Coming to disability, GCS was 15/15, pupil 2.5 mm, bilateral equally reacting to light. GRBS was 150 mg/dL. Coming to exposure, temperature was 98.8 degree Fahrenheit.
What is the importance of pupil in case of seizure?
So we can differentiate between a pseudo seizure and a true seizure. In a pseudo seizure,
Not possible.
pupil will be normal, but in a
Both the people will be normal. But how can it give a clue to differential diagnosis? That is very important.
Etiology, if it's anything like a brainstem involvement or something, we can actually have people in symmetry.
So if there is a raised ICP, that produces asymmetry. If there is a third nerve palsy, because of compression, it can produce asymmetry. If it is a brainstem lesion, it can produce small pupil. If it is due to some drugs, it can produce large pupil, or both drugs can produce small or large pupil. So pupil will give a lot of information regarding the possible cause of a seizure. Okay, it will not exactly tell you where is the lesion, but you can differentiate other differential diagnosis. So pupil is a very important feature in a seizure case.
Coming to adjuvants of primary survey, we have taken VBG showing pH of 7.40, PCO2 of 40, bicarb of 24, sodium of 135, lactate of 1.8. There were no acute
What is the importance
acid-based.
of lactate in this type of patients?
Sir, in a seizure, there will be increased lactate levels due to the
So many patients will
compensatory.
come with the malingering. So pseudo seizures. If you take a VBG and see lactate or simple lab investigation lactate, if it is low, then it is not a GTCS. And it can be a partial seizure or a malingering lesion. Okay, so lactate has got very important role in management of seizure in emergency room.
Other routine blood investigations and electrolytes were sent.
What are electrolytes you want to check in a seizure case?
So sodium, hyponatremia and hyponatremia both can cause seizures. Hypocalcemia, hypomagnesemia, hyperphosphatemia can all lead to seizures.
Both hypo and hypercalcemia both can produce seizures. Hypomagnesemia, then
Hyperphosphatemia.
hyperphosphatemia. Okay.
Coming to the secondary survey,
Blood sugar,
150, sir. 150
that is also important.
hypoglycemia.
Hypoglycemia can produce all types of seizures. Even hyperglycemia can produce seizures.
Coming to the secondary survey, the patient was a known case of bilateral SDH T2DM hypertension. The patient underwent bilateral barhole craniotomy and evacuation 1 year back. Right now, he presented with an episode of one episode of jerky movements of right upper limb, lasting for about 2 to 3 minutes. 2 such episodes were present.
Right side or left side?
Right side, sir.
Okay.
No history of any loss of consciousness, tongue bite, uprolling of eyes, involuntary micturition or defecation. No history of any GIT, visual or psychic auras. No postictal confusion were present. No history of any fever, headache, vomiting. No history of any weakness, slurring of speech, deviation of angle of mouth. The patient also gives history of skipped medications for the past 3 days. Coming to the past history, no similar episodes in the past. The patient was a chronic alcoholic and smoker. Drug history, the patient was on Levipil 500 mg BD.
Levetiracetam. Levipil is a brand.
Levetiracetam. Coming to systemic examination, CNS.
You see, levetiracetam is one of the most common drugs used in emergency room. What is the advantage of levetiracetam over phenytoin, phosphonatoin, phenobarbital? These are the first line drugs. Levetiracetam also first line drug. What is the advantage?
So less side effects.
What side effect?
Phenytoin can cause hyperplasia of gums, ataxia, diplopia.
Emergency room, you cannot produce hyperplasia. What is
Easy
that?
administration also.
It is the
Phenytoin
other
can
one
be
I say.
over 30 minutes.
Phenytoin is over 45 minutes. Phenytoin is 30 minutes. Levetiracetam also 30 minutes. What is the real advantage?
Drug interactions.
Drug interaction cannot. LFT. See, many patients whom we are treating for seizure is an alcoholic patient, chronic liver disease patient, some SDH patient. All these patients, phenytoin is contraindicated because of liver disease. Levetiracetam can be given in all the such patients. That is the main advantage for a ER physician. That's why now levetiracetam has become first line drug in seizure along with phenytoin. Okay.
Coming to CNS examination, power 5 by 5% on all limbs, tone was normal, cranial nerves were intact, gag reflex was intact, pupil normal and bilaterally equally reacting to light, respiratory system normal, vesicular breath sounds, air entry bilateral and equal.
Respiratory system, what you want to check in seizure patient?
Sorry, signs of aspiration.
Aspiration.
GIT, soft, non-tender bowel sounds were present. CVS S1, S2 plus, no other murmurs were noted. Our clinical impression was focal seizures without dyscognitive features, probably secondary to drug defaults.
Okay.
Then we taken a CT brain since the patient was a known case of SDH to look for any acute on chronic SDH, but CT show no bleeds.
Okay.
We have administered injection Levipil 1 gram IV stat since the patient
What
was.
is it? That 1 gram is it's not a good dosage for a ER physician. What is a per kg body weight dose?
20 milligram per kilogram bolus.
Okay, all drugs are 20 milligram. Okay, whether it is phenytoin, phosphonatoin, phenobarbital, levetiracetam, everything is 16 to 20 milligram per kg body weight. Okay, so how do you manage a seizure case in emergency room? That is most important. Whatever may be the seizure, whether it is a focal seizure, generalized seizure, whatever it is, how do you manage it? So this patient has come with seizure. He is already on levetiracetam. He has told he has skipped. That is the most important reason. So how do you manage? What are the triggers of the seizure in a patient who is having pre-existing seizure?
So it can be electrolyte. The most common cause is drug default.
Drug default is the most common cause.
Then it can be electrolyte imbalance.
Electrolyte imbalance, like what you discussed. Then
Can be trauma, tumor, or any CVA.
next common cause is sleep deprivation. The patient has not taken adequate sleep last few days. There is a second most important cause for seizure disorder. Then
If there is any infections, sepsis.
okay, that sepsis infection, all are causes for seizure. Here we are discussing a patient who is on drugs which was controlled for many years, now developing seizure. Okay, so in that drug default is the most important cause. So for that, what test you do? Ideally,
Levels of.
so we have to check any patient who develops a seizure when he is on some drugs. If possible, we have to send the drug levels. Okay, because most of these drugs have got very narrow therapeutic index. If it is low, patient will have seizure. If it is high, patient will have arrhythmias or other disorders. So drug levels, if possible, we have to send. If not possible, then you have to do the trial. Okay, so how do you manage a seizure case in emergency room?
So if the patient
Is coming to ER with the active seizure, status epilepticus, how do you manage?
So we will first put the patient in a recovery position.
It is not possible when somebody is seizing, you cannot put the patient on recovery position is only when the patient recovers. So before that, you have to sedate the patient. First is always sedate the patient. The patient is coming to ER, what will you try?
So possible we will go for 2 large IV.
That is first thing. We have to put a IV line. Okay, then
In active seizure through 1 IV cannula we will give benzodiazepines.
what benzodiazepine you want?
We can go for lorazepam 0.1 mg per kg dose.
Okay, first drug is lorazepam or diazepam or whatever, midazolam, whatever it is. So lorazepam is the ideal drug that we can give. Then
Midas we can give, if IV route is not possible, we can give Midas IM also.
okay, IM also you can give. If it is a child,
Diazepam per rectal.
Per rectal
Nasal
can be
spray.
given. Nasal spray is available. That's all. Nasal spray is available. Even adult also you can try that. If you are not getting an IV line, midazolam
About 8 to
nasal
10
spray
puffs can be
that can be given. Okay, then.
And
So once you give midazolam or lorazepam, patient will be sedated. So many seizures will get controlled. Then you can put the patient on left lateral position to avoid
Aspiration.
aspiration. That is a recovery position. Then you have to do some basic investigation like blood sugar, electrolytes, whatever you want, saturation, all these things.
then to prevent further episodes, we will give for levetiracetam.
What is the dose? We have already told. How do you dilute? What is the dilution? What is the route? How do you give?
Can give in 100 ml, and next we can give over a period of 20 to 30 minutes. We can
Minutes. If it is phenytoin,
for toin, phosphate is water soluble. Again, we can dilute and give. We can give faster, like even within 10 to 15 minutes also we can give as a fast
okay.
bolus.
Phenytoin.
45 over a period of 45 to 1 hour.
What solution you can use for dilution?
Deep.
Normal saline.
Normal saline, yeah.
Phenytoin, that is a problem. You have to dilute in normal saline. Whereas phosphenytoin and other drugs can dilute in DNS. Many patients will have hypoglycemia with seizure. So there you can dilute with the DNS and give. Okay. Then after first dose of phenytoin, phosphenytoin, levetiracetam, the patient is still having seizure. Then what do you do?
We can go for propofol.
Propofol can be given, but you tell me the steps. Follow the steps, then go for propofol. What is the next line of drug? So first line drug is given. What is the next line of drug? The seizure is not getting controlled.
For a second line,
Either same drug can be
same
given as a
drug can
second dose. Okay, you can give additional phenytoin dose, or you go for second line drug. What is the second line drug?
like phenobarbital.
What is the dose of phenobarbital?
20.
Same. All are. So you have to only remember 18 to 20 milligram per kg body. That is the dose for all drugs. Phosphenytoin, phenytoin, levetiracetam, phenobarbital. So that can be given. Even that is not getting controlled.
Then we have to think about intubation.
How do you
Then we
manage?
have to think about sedating and paralyzing the patient. So the ghost choice would be like propofol or ketamine can be used.
Okay. So why do you want to sedate, paralyze the patient in a seizure?
Actually, the duration of seizure prolongs. Actually, the complications can also worsen.
What complication?
Like aspiration or even alternate imbalances can happen.
That is not the reason.
Then it's incredible hypoxia.
Hypoxia is the reason. So other things are there. Whatever you told, that is there. We have to protect the airway. We have to intubate. Hypoxia has to be avoided. But hypoxia is avoided to prevent hypoxic ischemic encephalopathy because continuous seizure, brain requires more oxygen. Okay, so you have to intubate if the patient is not getting controlled with adequate seizure medicine. Okay, then. So once you put the patient on mechanical ventilation or whatever, you control the seizure with initial your treatment. Then how do you manage this case after that?
Basically, if it's like a new onset seizure, we had to go for an imaging, preferably like possible a CT as an emergency imaging. And
So what are the conditions you ask for a CT scan in a seizure patient?
if the history suggestive of anything like which can indicate like something like an ICU bill,
So in a new onset seizure, always we have to take an imaging, okay, CT or MRI, whatever is required. Otherwise, if the patient is already having seizure, on optimal drug therapy is getting another seizure episode, you have to take it. Okay, you have to send the drug levels, you have to take the CT scan. Otherwise, it is not really indicated in repeated seizures. Somebody is already evaluated for seizure, repeatedly is getting seizure during treatment, we no need to take a CT scan. Okay, here only because he has got an SDH, we are taking the CT scan. Okay, then what else we have to do for the patient? We have controlled the seizure, but whatever medicine we have controlled. What else we have to do?
EEG.
No, that is all done by a neurologist. I am asking what a ER physician has to do. That's all. EG has to be done. That is a question. There is no question that we should not do EG. But what else we have to do?
first thing is we will stabilize the patient about the seizure, then add one prophylactic medication. Then once the prophylactic everything is done and patient is stabilized, we have to continuously monitor the patient. Put him on continuous hemodynamic monitoring, and also correct any electrolyte imbalances if anything is coming up in the lab reports and all that. And also maintain normal physiology like normal glycemia, normothermia, everything we have to maintain.
Okay.
And also like restart the medication whichever drug default has
The
happened.
patient is not conscious, you have to do some more things.
But if the patient is not conscious, actually, it could also be non-convulsive status also, which we have to like emergency.
You have to put a rails tube, you have to put a catheter. These things are very important. Okay. Then only we will ask for a EEG test. Okay. Then
Um,
what is non-convulsive status? You can see in many patients in ICU they are not conscious due to some reason. They are having unconsciousness. So you can think about non-convulsive status. So how do you diagnose it?
Investigation shows the EEG.
Okay, there you have to do the EEG. Here, EEG is not a must. Once a patient regains his consciousness, EEG can be done afterwards. But in ICU, if the patient is not gaining consciousness, especially in encephalopathy or tumors, you want to assess whether non-status convulsive convulsion is there or not. We have to do a EEG. Okay. Then prevention of aspiration. What all things we can do? Once you protect the airway, mostly prevention will be done. Then other than that,
Especially the post-seizure phase, the patient is arriving or in ED also, we have to prop up the patient like about 30 or 30.
so initially put on left lateral position, prevent acute aspiration. Then you have to put the patient on 30-degree head end elevation, propped up position. Then
And
any antibiotics are required? Aspiration. What antibiotic you want to give?
ideally not required.
Ideally, it is not required. If at all you want to start antibiotic, what antibiotic you avoid? That is very important. You have to avoid some antibiotics. Fluoroquinolones and penicillins. Okay, because they all reduces the seizure threshold. That is very important. You can put azithromycin, you can put some other simple antibiotic, doxycycline. Okay, so we have to be very careful. You should not induce seizure. Okay, if the seizure is not getting controlled with your routine treatment, what are the differential diagnoses? Somebody is coming with seizure. After starting phenytoin, phosphonatoin, seizure is increasing. His urine color is red. What is your diagnosis? What is the diagnosis? Phenytoin aggravates seizure in some condition. Porphyria. So this is one condition where your drugs will fail. Okay. Porphyriasis, patient can have seizure. On starting phenytoin, seizure will aggravate and patient acutely develops hemolysis and red urine and porphyriasis, acute porphyriasis. In that condition, how do you treat? How do you manage acute intermittent porphyria in ER? High carbohydrate diet when the patient is seizing.
Just like any other seizure, we had to abort it using benzodiazepine.
You have to give benzodiazepine and dextrose. Okay, so these are the treatment options. There are also other drugs like other than phenytoin, phosphonatoin, phenobarbital, other drugs also can be used there. But best drug is levetiracetam can be given. Best drug will be benzodiazepines. Okay, how do you manage seizure in a pregnant lady? Term pregnant lady coming with seizure. What all things you will take care? Eclampsia. How do you manage? First is magnesium sulfate.
Same benzodiazepine can be used.
Benzodiazepine has to be given because you have to control the seizure initially itself with benzodiazepine. Then you give magnesium sulfate because that is a drug of choice there. Okay, how do you give magnesium sulfate in pregnant lady? What is the dose?
I give 2 grams.
It is very high dose. 3 to 6 grams you have to give IV. And during treatment you have to see the knee jerk. Okay, so hypermagnesium patient can go to hypermagnesium. There are different protocols. IM protocol is there, IV protocol is there. You have to see what is followed in our hospital. Okay, that's all. Okay, magnesium sulfate is the drug of choice. Okay, not phenytoin, phosphonatoin, other drugs. And other condition is what we are seeing is alcoholic patients who is having seizure. What are the differential diagnosis for that?
Can you Wernicke's encephalopathy then?
Differential diagnosis for seizure in an alcoholic patient. Wernicke's encephalopathy is one condition where the patient can have altered behavior, seizure, all these things. Then
Withdrawal.
withdrawal seizure is very important. Okay, then
Any trauma, head injury.
head injury, like this patient subdural hematoma. Okay, so that is the most common thing: trauma, head trauma, and withdrawal. Third one is thiamine deficiency. These three things you have to keep in mind. Okay, so in that patient, we have to always take a CT scan, CT head, and rule out bleed. Then you have to give thiamine. What is the dose of thiamine?
We give 500 mg.
Okay, how do you give thiamine in a patient who is having chronic alcoholism?
For the initial 3 days, we can give 500 mg TID, and then we.
Suppose the patient is having hypoglycemia.
First, we had to give this thing.
Thiamine or dextrose?
First, give dextrose, then thiamine.
First time.
First thiamine, then dextrose.
Then only dextrose. Why it is like that?
Because actually, in the
Huh?
energy utilization requires
Thiamine will be utilized very fast. Okay, so thiamine deficiency can produce further acute deficiency of thiamine in the brain if you give dextrose first. Always give thiamine and then dextrose. Okay. Now what happened to this patient?
The patient was taken for EEG, sir. Now currently under EEG for next 48 hours.
Okay. Why you want to do an EEG in this patient? Is it really indicated in a patient who is skipping the dose?
If the drug default is the most probable diagnosis, no need for.
No need to investigate the patient because he has defaulted the drug for 4 days. You can even check the drug level. Suppose you don't get the history. Once you know that it is a partial seizure, there is no need to actively investigate the case. You just restart the drugs, patient will be all right.
We do EEG if there is any different, like any new semiology in the partial seizure. Like compared to the previous and recorded documented partial seizure, if there is any semiology is variation to the presenting symptoms, then we might.
Jacksonian march.
Simple partial seizures from distal to proximal involvement.
Spreading of seizure with altered behavior. Okay, it will become partial to generalized tonic-clonic seizure.
So if any acute change in semiology, we might do a repeat EEG like that. Otherwise, there's no need. We just correct the restart the medication and like observe the patient, then we can discharge and follow up. Like.
In small children, less than 5 years, what type of seizure you get? What is a common seizure?
Febrile seizure.
Usually, absent seizure or febrile seizure.
Absent seizure means suddenly they'll fall down. Okay, they may not come to the ER, but febrile seizure they come to ER. How do you manage them?
Mainly by giving antipyretics and tepid sponging and all. Usually, beyond a certain age, you should listen to so about 5 to 6 years is commonly seen. So our initial management will be like to aggressively reduce the temperature. You can give suppositories or even tepid sponging and all too.
What are the differential diagnosis for febrile seizures?
Sure.
Febrile seizure means during fever patient is developing seizure. What are the differential diagnosis? Encephalitis.
Encephalitis.
CNS infection. Okay. In children, refractory seizures, how do you advise the diet in your ICU? Refractory seizure in a child. What are the other causes for seizure and what dietary advice should be given for that type of patients? Seizure syndromes. Actually, it is not required for ER physician, but at least when you are in ICU, should remember about the diet in chronic seizures. What diet you advise? What is the importance of ABG in that type of cases?
Log.
Here we have got a lot of cases who come with seizure in pediatric neurology. They take ABG. They see acidosis. What will you suspect other than lactic acidosis? What disorder? Protein.
The malabsorption syndromes.
Metabolism errors.
Involvement of metabolism.
Like lactose intolerance, protein metabolic.
What happened to them? Because their ammonia will be very high and they have mostly acidosis. How do you manage that type of child in your ICU?
One thing is to avoid that kind of this thing.
High protein
High protein diet.
Avoid high protein diet. That is the most important. So Adult, it is not a big problem, but child, when they come with seizure, we have to be very careful. Okay. What else is there? Anything else? Escalation? Nothing.
Yeah.
Okay. Thank you.
Okay, thanks.
Thank you.